Thank you, Chairman. I'm Hyeun from Nanori Hospital, South Korea. It is my great pleasure to give a talk in Korean American Spine Society. Today, my presentation title is that a safe route for cervical approach, partial pediculotomy, partial vertebrotomy approach for posterior endoscopic cervical foraminotomy and discectomy. This paper already published in World Neurosurgery Journal. As a surgical treatment for degenerative cervical foraminal pathology, ACDF is still considered the golden standard. However, with the recent development of endoscopic spinal surgery, posterior endoscopic cervical foraminotomy and discectomy has replaced many parts of ACDF. Endoscopic posterior foraminotomy and discectomy were initiated with the trans-V approach, and Kim et al. Reported a good result in the 2-year follow-up result in the European Spine Journal. However, the trans-V approach has been applied only to some limited cervical foraminal pathology. In order to expand the indications for endoscopic posterior foraminotomy and discectomy, a safer and more accessible surgical method to anterior parts was needed. For this purpose, partial pediculotomy and partial vertebrotomy approach were developed. With the introduction of partial pediculotomy and partial vertebral approach, the indications for endoscopic posterior foraminotomy and discectomy has been further expanded. In my recent study, it can be seen that a large part of degenerative cervical pathology, which was mainly operated with an anterior approach, is replaced by endoscopic posterior foraminotomy and discectomy. This study was performed on 30 patients who had received partial pediculotomy and partial vertebrotomy. And the inclusion criteria were patients with intractable cervical radiculopathy. The surgical method is to duct the endoscope at the V point, then expand the V point with the drill to expose the nerve root. And then after removing the pedicule of the lower part and the part of the vertebral body just above the pedicule using an endoscope drill, then after inserting the endoscopic working channel and providing nerve protection, after then, surgery was performed to remove the main pathology. We can check the V point in the endoscopic operation view. And after checking the boundary between the nerve and the pedicule, after partial pediculotomy, the target region can be removed. Postoperative CT images shows that the foramen is enlarged and a part of the pedicule is removed after partial pediculotomy and the partial vertebrotomy. However, this does not affect cervical stability. In the result, it was possible to confirm a lot of improvement in the VAS and ODI. Postoperative CT also confirmed that the foramen was sufficiently dilated. Now let's look at some cases. This patient is a 24-year-old male patient with a severe radicular pain and shoulder drop. After partial pediculotomy and partial vertebrotomy, the patient's shoulder drop was completely improved and the pain was completely resolved. This patient is a 29-year-old female patient who came to our hospital with severe radicular pain and grasp power weakness. After partial pediculotomy and partial vertebrotomy, the patient's grasp power weakness and pain were completely resolved. This patient is a 43-year-old male patient with severe radicular pain and left arm weakness. After partial pediculotomy and partial vertebrotomy, the patient's left arm weakness was completely improved and the pain was completely resolved. This patient is a 63-year-old male patient with severe radicular pain and severe foraminal stenosis. After partial pediculotomy and partial vertebrotomy, the foraminal stenosis was improved sufficiently and the pain was completely resolved. In conclusion, the uniportal full endoscopic partial pediculotomy and the partial vertebrotomy approach for posterior endoscopic cervical fluorotomy and discectomy, improved radiologic and clinical outcomes, providing a safe alternative techniques in posterior cervical decompression with a low rate of complication. Thank you for your kind attention.
Thank you. We're supposed to have a discussion, but let's do our last paper because our fifth paper is not here. Can you just, well, since he's here, how are you? Dr. Kim Hyun-sung, how are you?
Yeah, how are you? I'm Hyun Kim from South Korea.
Fantastic.
I worked in outpatient clinic.
Beautiful paper. My first question to you is that do you do this under general or patient is fully awake?
Actually, in Korea, I'm also doing so many thoracic and lumbar decompression, but I recommend to the patient general anesthesia due to the it may be happen during the operation, some mobilization may cause some nerve damage because generally I perform the general anesthesia.
General anesthesia. Would anybody else like to ask questions to? Okay, we have a question by Dr. Jeff Rowe.
Harrison, how are you doing? I have a question. Really nice paper. Thank you for the presentation. What percentage of your patients that you do the posterior endoscopic cervical decompressions are you doing the partial pediculotomy and partial vertebrectomy? Is it just a certain percentage, or are you doing it in all of those patients now?
Unfortunately, I can't hear completely sound because
I'll say the question. So he's asking, Dr. Rowe is asking, how many percentage of patients do you just do the foraotomy versus having to do the the vertebrectomy and the pedicle resection?
Yes, I'm also now studying about my cervical operation. Before cervical partial pediculotomy, I performed near 80% open HDF and laminectomy, but nowadays 90% posterior approach. And near all cases, if possible, I firstly apply to partial pediculotomy because of that. It gives some more safe insertion of working channel to the foramen and can protect the nerve completely. It means that near all patients doing the partial pediculotomy.
One final question for you. Does anybody else have a question? So, Dr. Kim, the question is how do you determine stability? Do you ever make the patient unstable? Do you check afterwards with flexion extension views?
Yes, I'm also now followed more than 3 years. I'm now another my paperwork about the instability of the cervical fluorotomy. Actually, you can see the partial pediculotomy usually save about more than 50% of the facet, but unfortunately, some of patients can aggravate more than 70 or 90 and 90% of facet damage. But I followed the patient more than 1 year and 2 years, and they have no checking some instability more aggravation. And I will publish the paper as soon as possible.
Okay, thank you. One final question before we go. The final question is, how long does a foraotomy take, like time-wise, a case like this?
Yeah. First time I also need a long time operation, but nowadays I already expert about the partial pediculotomy, and usually simple cases like some discectomy, it need less than 40 minutes, and it's some of patients who need some fluorotomy and oncovertebral resection patient need about 1 hour.
1 hour, that's pretty good.
50 minutes, yeah.
All right, thank you very much. Thank you for joining.
Thank you so much. Okay, thank you so much.